Hey guys, welcome to Cypress Basin Hospice Education Series, Hospice in the Nursing Facility, Part 2. Today we're going to talk about signs and symptoms of impending death, death and dying, what to expect in end-of-life care in a hospice patient. Cypress Basin Hospice is your community-owned, nonprofit, CHAP-accredited, Christian faith-based hospice serving Northeast Texas since 1986. With offices in Mount Pleasant, Paris, and Silver Springs, we're able to better serve our 16 counties. Being nonprofit, we're able to serve anyone in our area that meets hospice criteria, no matter insurance source or lack thereof. Neither does age play a part, as we are the only hospice in Northeast Texas to serve pediatrics.
What do most of us think a hospice patient looks like? Right. Usually by this time it's too late. Well, when is it that we first hear about hospice in our communities? Well, usually it's at church or at Bible study, and we hear, "Y'all pray for Sister so-and-so, they've called in hospice." And the whole church goes, "Oh." They gasp and the air gets sucked out of the building because they know in 2 weeks from now we're going to be having a funeral. So what do? We start gathering the casserole committee, get our Pinterest out for new recipes. We contact the funeral committee because we know that we're going to have a funeral in a few weeks because they've called in hospice. Why do we do this? Well, we've been conditioned to believe that hospice is only for the end of days rather than end of life. This myth has been perpetrated over and over and is the common accepted practice of many of those who even choose to use hospice at all. So why is it that we wait so late to utilize hospice care? Well, one, we believe the lie. We'll get to that in a little bit. We also think that it's our doctor's responsibility to initiate the conversation. Well, most of us know when we're going downhill, we can initiate that conversation, but we don't. We wait and we think the doctor should tell us if there's something wrong with us, right? Well, then we also believe, or we don't believe rather, that this could possibly be the end. The lie. What is the lie? Well, if you read in Genesis chapter 3, there's a story of Adam and Eve in the Garden of Eden, and then there comes this serpent. And the serpent comes and tells Eve, "You can eat of this tree, you will not surely die." And yet here we are thousands of years later, still believing the same old lie. "You're not gonna die. Surely no, not me. That's not gonna happen to me. That's not going to happen to my loved one. That's not going to happen to my resident." We believe this lie that we're just going to live forever. And yet we know the truth. The same book. God said, "You eat of this tree, you will surely die." There are two certainties in life, right? Two certainties. Death and taxes. And depending on how good of a lawyer you got, you might be able to skirt the taxes. However, nobody's been able to get out of this deal of death. So, we know this as a certainty, yet we refuse to believe that it will happen to us. We know it's a certainty. Why do we know it's a certainty? Well, because we have so many safety things on everything to try to keep us from killing ourselves. We have to wear seat belts in the car. You go and purchase a ladder. It's got 5012 safety precautions all over this ladder about what to do and what not to do. If you have a child seat, oh my goodness, the tags on that thing are just out of this world as far as how to properly install it. Otherwise, what will be the result in the event of an accident? Death, right? So we do everything in our power to avoid death, and yet we know it as a certainty, but we don't want to talk about it. We don't want to believe that it will ever happen to us. So, when we start talking about hospice, hospice is designed for a patient with a 6-month prognosis. What does that mean? That the patient, in the doctor's best guess, the patient will pass away within the next 6 months. Now, 6 months is quite a bit before, quite a while prior even, to the picture of the man at the graveside, right? That's a little late. So 6 months prior to that, they should have initiated hospice care. Well, hospice may look like for a patient at your facility, it may look like the gentleman whose dementia has, quote, gotten worse. And he's no longer able to speak full sentences. He's just word salad and making just garbledygook speech. Or he's lost his ability to walk. He's declined so far in the dementia scale that he's no longer able to ambulate. He's no longer able to even sit up without support. That hospice patient may also look like the lady with chronic COPD who has been back and forth to the hospital this year with recurrent pneumonia. Or exacerbations, or CHF exacerbations, or something to that effect. That Alzheimer's patient with multiple UTIs. Those are what hospice patients should look like at your facility. Let's talk about death and dying. Again, since hospice is designed for patients who have a 6-month prognosis, death is an expected outcome. We're not usually shocked by it. Now, occasionally, there will come a time when a patient will pass away, and we're all just very surprised because they didn't do like everybody normally does. They did things a little bit differently. Most human beings share many similarities and yet retain their own unique qualities that make them their individual selves. Death and dying does the same thing. In human beings, there are a lot of things that occur that are very similar. However, just as people live individually, people die individually. And so they do things very much their own way as well. I think of a hospice patient a lot of times like a Rubik's Cube. So if you remember that medieval torture device from the 1980s, you'll remember that there are multiple colored sides. And what happens, in my opinion, is as patients age, as people's disease processes continue to develop and get worse and even decline, what happens is they go to the doctor. They go to the one who can fix them. And that doctor, with all intents and purposes, says, man, I can fix you up. And they get to whittling and working on this Rubik's Cube, and they spin it all around, and they go, man, I got this red side looking really good. All right, I've got it all right. And then they look at the rest of the cube, and oh my goodness, it's just beat to death. There's green and yellow, there's orange and blue all over the place. But the red side's fixed. So he goes, man, I'm going to work on this green side and get this green side fixed. So he starts pulling back and he starts working on the green side, and the red side just gets all kind of messed up. Oh no, all right. This is what we're going to do. We're going to get that red side looking back good as we can, and we're going to go to hospice. Hospice then comes in, and we just pad that Rubik's Cube, and we fluff it up, and we put it in a little padded area, in a little nest, so that it is just as calm and as comfortable as it can be. Sometimes, the human body being an amazing creation, it sometimes starts working itself out, and some of those pieces get back in the right places. Other times, and most of the time, the maker of that Rubik's Cube has to say, I need to take this home for a closer look to spin it back to the way it's supposed to be. So that's one of the ways I look at when a patient comes to hospice. I also think of this idea of the bouncy ball. This example was given to me almost in a revelation, if you will. I was at a patient's house, and the patient was not doing very well, and the daughter said, yeah, but she's bounced back from this before. And so we talked about that for just a minute, and God just kind of gave me this idea of the bouncy ball. And what happens when we come to hospice is we take that bouncy ball and we drop it. And it starts out right up here, and it comes down, and it goes down, and we go, oh man, we're out of here. We're not coming back from this. And all of a sudden we bounce back. But yet we don't get back quite as high as we started from. And we come down again. And we go back up, but yet not as high. And we continue this motion until we get down in here to these slow little staccato bounces, and then we're rolling, and then it stops. Because we're not trying to do anything to kick that ball back up to where it came from. We're just letting it go and being as comfortable as possible, and letting nature take its course, and the human body doing what it does naturally. What to expect in a hospice patient? Well, we expect, of course, the patient to decline. Just as the bouncy ball There's going to be downs. There's going to be ups. And again, the ups never quite make it back to where they started. We expect to see decreased appetite, decreased endurance, decreased motor function, decreased levels of consciousness. We expect to see increased pain, breathing difficulties, fever, skin breakdown, anxiety, and incontinence. Now, this is not an in-order list necessarily, but we do expect to see these things throughout the course of a patient's hospice stay. What do we expect to see with the imminent patient or actively dying patient? The imminent or actively dying patient is exactly what that sounds like, is that the patient could pass away at any time. We expect the oral intake to have decreased to sips only, and maybe even none at all, and only using mouth swabs to moisten the mouth. Decreased output. Of course, less in is going to be less out in most cases. We expect to see mottling, see apnea, or the absence of breathing. We expect to see fever in some cases. Ultimately, we anticipate the patient to go into what is known medically as a coma, or they just fall asleep, and then ultimately death. I often get asked on admits, Wes, how long do you think so-and-so has? Well, that's very difficult to determine. However, I do look for signs and symptoms, and if I do see any of these, I obviously tell the patient's family what I'm seeing and what I'm guesstimate in my years of experience in hospice care. I look for discoloration in the feet, discoloration in the lower extremities. I look for cyanosis to the toes, to the fingers. Basically, what happens as the patient becomes imminent and actively dying, the heart and the brain say, all right, boys, we can live without our fingers. We can live without our toes. Quit sending them the good oxygenated blood. We want to keep it in our core. So what we see oftentimes is that decreased oral intake, decreased output, mottling, apnea, fever, and then ultimately we see the patient go into medically a coma and ultimately pass away. Now, what does hospice do for that imminent patient who's actively dying, who's only taking sips and no oral intake? Well, we support and we educate the family, and we palliate for the patient. The body's not really hungry at this point, yet it is designed to self-sustain as long as possible. So it's pulling from those fat stores, those muscle, the atrophied muscles that they're not using, and the body is still producing what it needs to do as long as it can to sustain its life. Decreased output. Again, we support, we educate, we palliate, and instruct that, of course, less in is going to be less out in most cases. Modeling. Support, educate, palliate. The body, again, is redirecting that good oxygen to its core, to those vital organs. We teach the family environmental changes in order to help keep the body warm if the patient feels cold. Apnea, support, educate, palliate. Teach the family that the patient's lungs are just tired. As you see that apnea, usually what happens is the patient's breathing along, and then they pause. Usually it's for 5-10 seconds the first couple times, but as the family is sitting there watching this patient, the first time they do that, if they're not ready for it, if they don't know that this is coming, it scares them to death. I mean, it feels like it's 30 minutes. And I tell the family, when this happens, it's going to be 5 or 10 seconds, maybe 15, but it's going to feel like half an hour when it first happens. And everybody starts leaning in and patting and trying to, oh, is this it? Is this the last one? Or did they just die? And we educate them that this can happen over and over, and that period of time will elongate over time. And again, it's like the lungs are just tired. They're breathing along, and they just have to rest. They've done all they can do for right now. And then all of a sudden, after that period of apnea, whether it's 5, 10, 15 seconds, all of a sudden you'll start seeing the patient will start breathing again. Sometimes we see fever, depending on whether or not the patient has issues with their hypothalamus, if they have cancer that's metastasized to the brain, or if they've had a stroke or something that involving the brain, a lot of times we'll see the hypothalamus gets uninvolved, and therefore their thermoregulator is out of whack, and sometimes they can have out of control fever. We call it terminal fever. And a terminal fever is a fever that you can give it all the Tylenol you want, you can put the cool packs on, you can wipe them down, have the fan on them, and the fever's not coming down. One thing I have noticed over the years in patients who do have this terminal fever, we don't see the mottling quite as severe as in other patients. Coma. Again, we support, we educate, we palliate, and we teach the family that this is okay, that the patient is sleeping, they're resting, and it's all right. Most folks' goal for passing away is to go to sleep and not wake up. And in this case, that's usually what happens in most hospice patients, is they go to sleep and they don't wake up. Whether they go to sleep on a Tuesday and don't pass away till Saturday, the end result is the same. They went to sleep and didn't wake up. Death. We support the family. They need a lot of help at this point, because most of the time this is the first time they've had to deal with this. So we give them a lot of guidance and support in calling the funeral homes, getting all that set up for them, offering bereavement support, grief support after the patient has passed away. Two other items I want to add to this slide that we see oftentimes is increased heart rate and decreased blood pressure. It's not at all surprising to see an 80/40 blood pressure in an actively dying patient, nor is it at all surprising to see a heart rate of 125 to 130. And again, how we treat those is still palliatively. We use the morphine for pain control if they're having any pain issues, for shortness of breath. We, of course, hold any medications that might need to be held, such as blood pressure medications or anything like that. Coordination of care. One thing I do want to add to this slide that's not on here is when a patient passes away at your facility who is on hospice, Cypress Basin Hospice comes with an RN to pronounce that patient. I know a lot of you guys' facilities have DONs who are there available most of the time, even during hours or even after hours. Some facilities want the hospice to come take care of all of it. Cypress Basin Hospice sends the RN day or night, business hours, after hours, to take care of pronouncing the death and taking care of those steps after death, calling the families, calling the funeral homes, making sure that all of those things are taken care of. Also, in coordination of care, as we discussed before, communication with the family, with the patient, and with the hospice, they are imperative to meeting the patient's needs. We talked about facts and feelings in the last video. Feel free to reference that. Also, we've talked about the black binders, what we have there at the facility with you guys. And again, I want you guys to think of some people. I want you to think about who in your facility is not going to be here in the next 6 months, who's not going to be at the next holiday party, who's not going to be at the Christmas party, who's not going to be able to make it to the 4th of July party next year. So, I mean, just have those folks in your mind. The patient that keeps getting shipped out, that patient that is, quote, going downhill. If you've got somebody in mind, tell your charge nurse, tell your DON. Let them know that this person needs a hospice referral. It is imperative that they get that referral early, at 6 months prior to end of life, or even before that, as opposed to 6 days before end of life, as opposed to 6 hours before end of life. Before we start seeing all of these signs and symptoms of impending death, we should already have had a hospice referral. The idea that, again, planning for end of life is not dissimilar from planning other events in our lives. I've talked about in other videos and in other talks, I've talked about planning. And as far as planning goes, we don't plan our birthday parties the day of our birthday party. We don't plan on having a baby the day we have a baby. We don't plan on dying the day that we die. You plan all that stuff out ahead of time so that when it comes, you're ready. Think about it. There's 2 dates that go on a tombstone: the day of your birth and the day of your death. We should spend a little time planning for that second day, the second most important day, if you will, of our lives. We should spend a little time being prepared for that, not rushing all at the very, very last second. So remember, these folks need a hospice referral. God bless you guys. Thank you for your time.
Thanks for watching this video. If you have questions about this video or would like to receive further instructions about this or another topic, please feel free to give us a call at 903-577-1510. For Cypress Basin Hospice, I'm Wes Smith.